Good afternoon. I would like to introduce Professor Harry Moseley, that is professor at Nine Wells Hospital and Medical School at University of Dundee, United Kingdom. He has an international reputation in the field of UV spectroscopy and development of new UV measurement techniques. His publications cover UV dosimetry, assessment of sunscreens and clothing, dermatological laser application, and so on. We would like to thank you for your travel across the ocean to come to Brazil to share your experience with us, Professor. Thank you.
I am now turned on. So, thank you for the warm invitation, and it's good to be in Brazil. It's some years since I've been in Brazil, and it's my very first time in San Carlos. So I'm enjoying this very much, and I hope you get something out of this talk. The way I talk, I expect people to interrupt me. At some point, somebody's going to say, I disagree with you. Well, please do so. Just say that. Just say you disagree. At least it will get some discussion, It'll be good. Now, I want to start off with some kind of basics so that we all are coming from the same point of view. Now, for those of you who know all this, this is a great opportunity just to catch up on some sleep. But if you don't know it all, then you can just say, listen in, and you can correct me in the bits that I get wrong. Now, if I press this button, no, I haven't got that. Try that. Oh, there we go. Okay, for those of you who don't know, this is the UK, United Kingdom. These are the centres which are currently practicing PDT, Photodynamic Therapy. This is us, a little smiley face, way up in the north in Dundee. It's still winter. It'll be winter right through till about September, and then the next winter starts again. So that's where we are at the moment. And within Scotland, which is the cold bit in the north, there we are, Dundee, these are the centres that we've set up to carry out skin PDT. What we did was we were very, very keen on PDT as a treatment. We saw lots of advantages to it, but it was always difficult to get funding. And I don't know how long have I got, an hour or two? 1 hour, only 1 hour. Okay, so this lady had a lung cancer, and she had gone to Edinburgh, and they had given her radiotherapy, and they couldn't do any more with her. So they said to her, I'm sorry, you have to go home to die. And her husband didn't think that was quite acceptable. So he discovered, reading the newspaper, about a treatment called PDT, Photodynamic Therapy. And he found this centre in Yorkshire, which is in England, which was carrying out PDT for lung cancer patients. They went down and had a treatment. The long and the short of it is, she lived for almost 7 years with a good quality of life. And before she died, she said she wanted to make sure that other people could get the opportunity to have this treatment that she had as well. So she started going around various hospitals, she and her husband. The first time I came across them, I'll talk about PDT in a minute. The first time I came across them, I had given a talk in a hospital. And then I went to the car park with this gentleman who was her husband. And I got into my little car. I noticed you have the Volkswagen here, the Volkswagen Beetle. Well, mine is even older than that. And this gentleman got into his Rolls Royce, like physicists over here drive, big Rolls Royce. So I thought, oh yeah, this guy must have some money. And so we were very nice to this couple. And we actually spoke with them a lot of times until they decided that they would support a PDT centre in Dundee in Scotland. And that's how we got the PDT centre set up. It took a lot of money, but they were very, very generous. And although the lady herself has died, the husband carried on supporting the unit. And we now have a regular income coming into the charity from that source. So that's just a little bit of background. But one of the things we wanted to do, although we were here in Dundee, we wanted to make sure that as many people as possible within Scotland could have access to PDT. So we trained people we sent out research nurses into other hospitals to try and show people how they could do PDT, spent a lot of time explaining the treatment to the relatives and also to other doctors, because it's a very different kind of treatment. Now, I better get started. Here we go. Right, this is Dundee. This is where I'm based at the moment. This is our hospital called Nine Wells. Somebody was asking me, are there 9 wells? I don't know. I've no idea why it's called 9 wells. And I suppose there must have been 9. I've never seen them. I don't know. This is the River Tay, which, if you go up near the source of the River Tay, is the best salmon river in the whole of the United Kingdom. That is the top salmon river. If you like fishing for salmon, personally, I prefer to go to the supermarket. It's a lot easier. You don't get wet and cold, but there you go. So, moving on. We have a lot of this sort of thing in Scotland as well. It's a beautiful country when it's dry, which isn't very often. But even when it's not dry, there's mist and there's atmosphere and there's monsters. You've been to Loch Ness. How many have been to Loch Ness? Yeah. And did you see the Loch Ness monster? Did you? You've seen him, yeah. Big thing with humps and stuff, yeah. If you have 1 or 2 whiskies, the mist clears. And it's a lot easier to see the Loch Ness monster. Oops, better go back. We also have a lot of this sort of stuff in Scotland. It's very noisy. It's probably illegal, the noise these things make. And of course, we like dressing up in skirts and dresses and stuff. It's just one of the things that we do. Pardon? Yeah, it's not me, no. So anyway, that's a little bit of background of Scotland. Right, I'm not going to sing, although somebody was telling John Gherkin, who's a much, much greater authority than I am, if you've got any difficult questions, we've already decided that John will tackle them, because I won't give you a chance to ask them. I'll just talk until there's no time left, and then John will answer the questions. John was saying, was it you, John, where you're saying you were at a meeting and this guy started to sing? It was very good. Was it you? You were singing? You were singing. Tonight, maybe? We'll hear the sound of music tonight, perhaps. Okay. So, PDT, it's a treatment primarily for cancer in which a drug is retained by tumor and then activated by light. You probably know this already. There's other things. You can use PDT for treating other conditions as well. But what I want to focus on in this talk is just a little bit mainly about treatment of cancer, and just focus in on that. It's also important to know what it's not. It's not radiotherapy, it's not chemotherapy, and it's not surgery. Now, the reason I'm telling you this is that within hospitals, there is a huge number of people, if you've got cancer, who will want to give you radiotherapy. There's another big number of people, if you've got cancer, will want to give you chemotherapy. And then there's another big group of people, if you have cancer, will want to perform surgery on you. So these are great big power blocks where people have spent years in training, and they now know so much about their subject that they want to be able to practice that art that they have perfected. But PDT isn't any of these things. And that's one of the reasons why it's quite difficult to get PDT treatment carried out in hospitals, because it doesn't fit into any of these categories. And that's just a fact of life, and it's something we have to live with within the clinical arena. I should say, for those of you who are wondering about kind of what is my background, what am I doing, well, these are 2 separate questions. My background was in physics. I did physics degree, I did PhD. I worked within a dermatology department, very much supporting clinical research. I'm head of scientific services within a dermatology department. So it's very hard to know what exactly I am. The second question, what am I doing? Well, that's even harder. So the other side of PDT is this photodiagnosis. And this is quite interesting because you use the same drug as you use for PDT. So you don't have to change your drug. You can use the same drug, but this time you excite it with a different wavelength of light. And this causes the drug to fluoresce. And since the drug accumulates in tumor cells, this can be used to localize the tumor. And it's useful for tissue-sparing surgery. And we do this a lot. In fact, a lot of our PDT photodiagnostic work now is with surgeons, particularly in brain surgery, where we use the photodiagnosis to isolate the cancer cells during the surgical procedure. And I'll show you a little bit more about that as time goes on. Now, yeah, you may think to do PDT you need a big laser. This, in fact, is a slide, a perfectly genuine slide. That's red light, it's not blood. It's red light. This lady had some sort of cancer on her knee. This isn't my slide. This came from Southampton, in fact, this slide. There's a dye laser pumping, or there's something pumping a dye laser, I'm not sure which. There's a power supply, which is the size of 2 filing cabinets. Basically, you need quite a large room to occupy this for this laser. When we started doing this treatment, when I was in Glasgow, another city in Scotland, we were doing this on bladder cancer. And we had a copper vapor laser, which was so big, it was outside the theatre. The power supply and the laser were massive. And we had a hole drilled through the wall, and the fibre went through the wall, and then the treatment was carried out inside the theatre. Because these were big machines. And we had a technician that spent most of his time trying to, here's a nodding, you know about these, nodding, trying to keep these lasers working. On a good day, you could get a bit of water too if you were really lucky. They were absolute nightmare, but you got respect. You see, as a physicist, what you really crave for is respect. You want people to think, wow, he knows how to make that laser work. He can make that sing and dance. And you got respect with those machines. Nowadays, it's just a little box. You know, it's something your kids could probably start and use quicker than we could, you know. So the respect has gone out of this. So there's no longer a high-tech treatment. The other thing about PDT that a lot of people think of is this question of photosensitivity. So if you're getting PDT, you'll be given a chemical which will make you sensitive to sunlight. Now, I know, because I've heard clinicians say, oh, the problem with PDT is you make the patient sensitive to sunlight. They can't go out. This was one of our colleagues who dressed up for the photograph. I thought the flowers a nice little touch there. And that's that. In fact, I went into a recovery room where somebody had PDT for it was some sort of cancer in her gut. And they had put black bags over the windows. And the first thing I had to do was take that off the windows and start letting some light in, low controlled levels of light, so that you can photo bleach the patient. Otherwise, it's a condition to live in. You might as well die as just live on in a darkened room, not being able to see anybody or anything, bumping into stuff all over the place. So photosensitivity has been exaggerated. Photosensitivity is a reality that is easy to manage. We manage these patients regularly because it's controlled exposure to sunlight. You can give them a little meter to take away, and they can find out how much light there is, and they get back to normal living fairly quickly. So there's all that stuff around PDT, which gets people confused. This summarizes it. It's not a thermal technique, which is rather good, because it means you're not damaging healthy tissue. You're not coagulating. You're not. You're keeping the structure of your tissue the same. It does require pre-administration of a drug, which is a photosensitizer, which is then activated by a specific wavelength of light. And of course, this treatment requires oxygen, which generally is not a problem. There's usually plenty of that around. The combination of light and drug and oxygen forms a highly reactive cytotoxic species. So in other words, you've now created something which is going to kill off cells. And this then produces localized tissue damage. So you're not damaging lots of areas of healthy tissue. You're only damaging more or less where you shine the light, because your cytotoxic species that you create has got a very short life, so it doesn't get very far. This is a wee picture. There's the light. There's our drug. Chromophore just means a molecule that absorbs light. So we have this drug chromophore that absorbs the light. The light gets it into an excited state, the result of which, with an interaction with oxygen, you'll produce photoproducts or free radical formation, and if it's in a test tube, you'll get substrate effects, or you'll get killing of cells round about where this is happening. there's actually quite a number of potential targets for PDT, and everything that I've marked up here can be, in certain circumstances, reacting to PDT. We've shown this in DNA. Other groups have shown PDT effects, and all of these, we've also shown it in microtubules. So depending on your photosensitizer and your time between administration and illumination with light, and your light levels, some or all, but probably just one or two of these will be targets. So when we say it's a specific treatment, that's only partly true, because potentially we can hit quite a lot of things when we're doing PDT. This just says in words what I've been trying to yabber on about. Absorption of light, photosensitizer, is oxygen-mediated, either direct or indirect production of species, such as singlet oxygen, that cause cell death. The reaction of the cytotoxic species with subcellular organelles, such as I showed you in the picture before, and molecules such as proteins and DNA, will lead to either apoptosis or necrosis of the cells hosting the photosensitizers. In other words, you kill cells. Now, if you do it by apoptosis, then that's controlled cell death, the kind of suicide of the cell. If you do it by necrosis, you cause a lot of peripheral damage, and obviously apoptosis is preferable to necrosis, but either way, you kill the cell. I put this up, although it's taken from a very old publication, which in fact is really, this publication isn't about PDT, but it's probably the main clinical site of damage when you're carrying out PDT. Around the cells, there's a bilipid layer. So you've got these two lipids round, that's your cell membrane. There are glycoproteins which go between them, between the two layers of lipids. That's the outside of the cell, this is the inside of the cell. Now, when you carry out PDT, the cell membrane is one of the primary sites of damage. You'll find that the sensitizers, the photosensitizers, tend to localize on the cell membrane. Again, it does depend on the time between administration and illumination. Once you have your sensitizer sitting there and you illuminate with light, you then see that your bilipid layer is now looking quite different. There's increased ion permeability, there's a loss of fluidity, there's cross-linking of these lipids and polypeptides, and there's inactivation of membrane enzymes and receptors. So in other words, you have done serious damage to the cell membrane by the action of PDT. So that's your primary site of action when you're doing PDT treatment of cancer. It's a bit like sticking a pin in a balloon. You know, it was working fine, but now your inside and your outsides have got a bit mixed up. So, as we said, PDT-induced cell death by apoptosis or necrosis. Cell membranes are a primary site of action. There's also functional impairment of mitochondria. And again, this is important very often. PDT also acts on the vasculature. So you can actually destroy the vessels, the blood vessels, using PDT. And that's used in various treatments such as senile macular degeneration. This is just a wee diagram which we can probably skip. I'll mention it since I put it up. Basically, you've got your molecule sitting in its basic ground state, a singlet state, so your two electrons are spinning in opposite direction, so they're matched. Excite them, you'll now lift one of them to a higher energy state, and so on. So these are all singlet states, so that's the excited state. At this point, you may lose energy by fluorescence, and your molecule will just drop down to the bottom, or you may get intersystem crossing, where you cross across into this triplet state, where you now see that the two electrons are both spinning in the same direction. That's a triplet state. And that's a more stable state. So instead of getting rapid fluorescence, you'll get the slower phosphorescence decay from the triplet state. Now, this applies to most molecules. It does not apply to oxygen. Oxygen is rather unusual in that oxygen, actually, the excited state of oxygen is a singlet state. Its ground state is triplet. So it's a little bit different from most molecules. This is a wee diagram which I think helps to kind of put it together. We have the sensitizer. We flash our light onto it. And we've got two types of reaction which can take place. The so-called type 2 reaction is the most common. So we've now got an excited sensitizer, and that excited sensitizer then interacts with oxygen, which is sitting round about, and creates this singlet oxygen. So instead of having triplet oxygen, you've now got singlet oxygen. Singlet oxygen is highly reactive. And singlet oxygen just wants to do damage. It's a bit like, I don't know, an 18-year-old kid. You know, I don't know what you've got over here, but certainly in the UK, an 18-year-old lad just wants to do damage. Well, he's a bit like this. All singlet oxygen wants to do is do damage. So if there's any cells round about, they're in trouble because singlet oxygen is just out for a good time, and it's going to kick any old cells that it can find. Now, that's the type 2 reaction. The type 1 reaction is a little bit different. In this case, you have the excited sensitizer, which produces radicals. The radicals then interact with oxygen, and via superoxide and hydroxyl radicals, again, they're out for a good time. It's a Saturday night, and they've just had a wee bit too much, so they're going to cause a lot of damage as well. So one way or another, you're going to cause some damage. But generally speaking, for a clinical reaction, it's usually via type 2 and singlet oxygen. I think this just says the same thing. It just looks a little bit more scientific than the previous diagrams, but I don't think there's anything in there that we haven't covered already, other than possibly I should say here, this business of photo bleaching. When you return your sensitizer, in this diagram we've put PP9, which is a photosensitizer. When that goes back down to the ground state, you then find that the singlet oxygen reacts with the PP9. So the more singlet oxygen you produce, which kills the cancer cells, the more you knock out your actual photosensitizer. So this is called photobleaching. So as you're killing your cells, you're destroying your photosensitizer. Now, hold that one, because I think it's tomorrow morning, I'm going to do a little talk where we're going to look at this photobleaching a little bit more. So it's a metric for singlet oxygen production. In other words, if you're producing singlet oxygen that's killing cells, you're going to see photobleaching. And if you're not seeing photobleaching with these kind of photosensitizers, then you've got to wonder, well, I guess we're not producing much singlet oxygen. So we'll come back to that tomorrow, if you're not too confused by then. Now, the mechanism that I showed you before was a straightforward PDT using a photosensitizer. But if you're doing PDT on the skin, you're probably not going to use a photosensitizer, which may sound a little bit strange, but I'll just explain what you're doing there if you don't already know. You're going to use this thing called the heme biosynthetic pathway. This occurs within almost every cell of the human body. You go round this stepwise progression until you produce heme, which of course you need for hemoglobin. Right, now, supposing you overload your cells with 5-ALA. 5-ALA is not a photosensitizer. So you put in plenty of 5-ALA, now that's going to work its way through the system. You've got a lot of traffic going down the motorway. It's going down, 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 down. Oops, here's a problem. There's a lane closure. And at this particular point, because you've got a lane closure, you've got a build-up of PP9. PP9 is a photosensitizer. So in other words, you have overloaded the cells with 5-ALA. As a result, the cell itself has produced PP9, which is rather neat. So you haven't given them the photosensitizer, it's done it itself. And of course, if you can set up a system where you're doing this to more cancer cells than normal cells, then you get a preferential kill of cancer cells, because you've now got this photosensitizer, you whack that with some red light, and hey presto, you've got a PDT reaction taking place. Yeah. 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 Time scale. Okay. Yeah. Okay. If you're looking at administering a systemic photosensitizer, your time scale there is of the order of 2 or 3 days. So you inject in and you let that get round the body until it's got a preferential uptake in the cancer rather than the normal cells, and then you illuminate. So that's 2 or 3 days in between. If you're doing this on skin, you're talking about a few hours. Depending on the drug, it could be 3 hours up to 6 hours. So you apply the cream, the ALA penetrates into the skin, it then produces PP9, wait 3 or 4 hours, and then you shine the light. In different hospitals, it's slightly different regimes, but there's round about that. They're all working similar to 3 or 4 hours. Yeah. Yeah. How long does it take? I don't know, because the whole thing is time from applying the ALA to the surface of the skin to seeing the fluorescence. So you've got time for the ALA to penetrate the skin, and then the time to convert from ALA to PP9. I think the conversion is fairly quick. If somebody else knows the answer, don't sit shy. I'm quite happy for somebody to chip in. I know the overall thing is a few hours, 3 to 4 hours, between the penetration and conversion. Okay? Yeah. The reaction itself, okay. It could be, you've got your, I think it's quite fast, but I'm just I'm struggling. Yeah, yeah. Yes. Sorry, are people hearing this at the back, the discussion? Can you hear it? The question is, how long does it take to convert the ALA to PP9? And we think that's a matter of minutes, that most of the time is penetration through the skin of the ALA to the various cells. I've got a little sort of cartoon for those of us who have found this a wee bit kind of difficult to get our hands on. So there's 2 ways of applying the sensitizer. It can either be ALA in a cream, which will then get to the tumor and be converted, or if it's a systemic, if that tumor's not in the skin, if it's in your lungs, for example, then we inject the photosensitizer. It will eventually be taken up by the tumor, and you're kind of waiting until you've got a preferential uptake in the tumor, and then you shine the light. If your tumor's near the surface, obviously you can use LEDs or something like that. If it's in your lungs or somewhere else, then you apply a laser beam through an endoscope and destroy the tumor that way. It looks quite straightforward when you see it like that. Hey presto. So there we go. That's how it's done. There are some commercially available sensitizers. Now, this isn't an exhaustive list. There are more now on the market. These are the ones that we have experience with, and you've probably got some in Brazil that we don't have over in Europe. And I know that there's some coming in from Russia and Eastern Europe that we haven't started to use yet. But these are the ones that we've got experience with. These are photosensitizers, Photofrin and Phoscan. Visidyne also, but that's for that's used in eyes. This is your ALA. Metvix is methyl. That's an esterified version of ALA. The idea being because it's got an ester stuck onto it, it will penetrate through the skin a bit quicker. The other thing is, if you want to patent it, you've got to do something to it, because anybody can produce ALA. So there's, commercial companies are looking for something special, and that's where the Metvix comes in. These are just some of the systemically administered sensitizers and some of the topical ones. Amulose, that's a new one that's just appeared. It's got some sort of nano emulsion on that ALA, which we are just about to start using. The traditional ALA, I mean, the thing about this is that I started doing PDT, although I'm not a clinician, I started doing PDT using laboratory grade ALA, and you may still be doing that here, I don't know. Eventually, we were told we couldn't do that, but we had treated so many patients successfully that, well, we had to stop because we were told to stop. We then found a supplier who could supply us with clinical grade ALA, but now, see, ALA in the UK doesn't have a license. It's an unlicensed product. This company, Galderma's, come along. They've licensed their form, their product, Metvix. They've got the ester on the ALA, and now we're having to buy the Metvix, which is very expensive compared to what we used to do. I could treat a patient for £4, which was about $6. It's now about $300 to $400. It's not any better. It's exactly the same. We've done lots of studies, and we're not getting any difference between the two. But that's life. What do you need to do PDT? Now, I understand that you're setting up, or you have already set up PDT centres in Brazil, similar to what we've got in Scotland with centres doing skin PDT. You don't need very much. A bit of debridement, which is basically just taking off the kind of rough scale, on top of the tumour. Apply the cream, put a dressing over it, leave it for 4 to 6 hours, remove the dressing. We usually use what we call a Woods lamp, which is an ultraviolet lamp, to see fluorescence. That red light, that red is fluorescence. And that's showing that we've got a good, strong uptake of ALA conversion to PP9 within the tumour. Mark out the boundaries that we want to treat. This particular case we were treating with a laser, and we've got a nice bit of illumination. Immediately afterwards, there's a little bit of erythema and edema just round about the lesion, and then that heals up. Now, if anybody wants to see an example of a PDT-treated lesion, come afterwards and have a good look at my nose. Now, this here had a nodular BCC, and now I wouldn't actually recommend using PDT for nodular BCCs because they can be quite deep, but this was a very, very small one. So I said, we'll have PDT in my nose. Now, it's a bit nippy. In other words, it hurts. But I am a man. I am sensitive to pain. That's the difference, or one of the differences. You see, ladies get this treatment and it doesn't seem to bother them, but us men, we're very sensitive creatures. And I think the girl that was doing the treatment gave me more watts in the laser than I really needed, and it certainly was a wee bit nippy. Anyway, it was fine. And as you can see, maybe you can't when you are. That nose is as perfect as it's ever going to be. So, yeah, it works. It works very well. These are some of the early cases that I did before we had the dermatologist getting interested in it. This is a condition called Bowen's disease, B-O-W-E-N, which is it's a locally invasive, but it doesn't metastasize condition. And you can see this has been left for a very long time. We did 2 PDT treatments, and that's the sort of result that you can get, which is a very, very fine result, and obviously a good result for the patient. This was probably the one that clinched it. We had a lady with lots of lesions, superficial basal cell carcinoma, round about here. She had some on her back, which had been surgically excised, and she had skin grafts. So she was a bit of a mess, and because this was a superficial lesion, we decided that we would try PDT. So again, I gave her 2 courses of treatment, and almost all gone, not quite, but you can always pick up little bits and pieces afterwards if there's something that's not treated. And that really swung it in our centre. We were now convinced that PDT was a treatment worth offering to patients. That's the back of the lady, and you can see the plastic surgeons have already been active with her. Other conditions, we get a lot of ladies with lesions on their lower legs, what we call field change. In other words, there's a lot of abnormal tissue. There's sort of precancerous changes going on there, as well as Bowen's disease and basal cell carcinomas. So that's kind of a good sort of candidate for PDT, because to start to individually cut all these things out would be extremely difficult. There's a close-up before and after treatment, and that was just a single treatment. We now routinely do 2 treatments because we do see recurrence. I think we've got some stats coming up shortly. Yeah, these were the results we produced a way back a decade ago when we had done, well, 200 odd cases. And you can see we were getting clearance rates of about 90% with a follow-up of around about 48 weeks. If you go on a little bit longer, you do see recurrences. And what we do then is just give them additional treatment. And if they're not responding, then of course you can have a local excision or a cryotherapy. We did a comparison with cryotherapy, and we found that there were a lot more side effects from the cryotherapy than from the PDT. So PDT would be our treatment of choice. But again, if somebody says, what about recurrences? Yes, there will be recurrences in some cases, in which case you treat the recurrences. These are by and large fairly localized tumors. They're not likely to metastasize. They are superficial. And you'll see from the modeling that I'll present tomorrow that there's a good reason why we should be careful of our patient selection and only treat superficial lesions. That's just the same data, but if you put it in a graph, it always looks a bit better. And you can, as I say, although we were talking about cancer, there are a few other things you can treat. I mean, this was a wart, which we cleared. Warts are difficult things, and sometimes work and sometimes don't, and they also hurt. Come on. This is what, well, I'm not sure, because before I came away, I asked to get an update on the number of lesions that we had treated. And I get 2 different figures. I think one was about 7,000, which is what I put in the abstract. And the other set of figures came through at 5,900. So somewhere between 6,000 and 7,000. Obviously, our numbers aren't terribly accurate, but it's somewhere around about that. That's the number of treatments that we have carried out, mainly for Bowen's disease or superficial basal cell carcinoma. And we're still carrying on doing this treatment. It's very popular. And it's still very successful. As I say, what we did in our centre was set up the Scottish PDT Centre. I've called it a virtual centre because when we put forward our plans and how the centre should be developed, we said we do not need an expensive building. We can use the facilities which are already in place in different parts of the hospital. So we formed liaisons with different clinicians in different parts of the hospital, as a result of which you can see we've done quite a lot of work in brain, oral cavity, GI tract and gallbladder, the bladder, and in the lung. That's in with that, and we've already talked about skin. So we've done a lot of treatments over the years. Now our main site of activity is brain and also in bladder with photodiagnosis in the upper ureter tract, which we're working on there. If you're wondering how do you administer a photosensitizer, it's quite straightforward. Just inject slowly. You kind of dim the lights, and because your patient is going to become photosensitive, and over the next few days and weeks, you'll control the lighting. This is a lung PDT, which is actually in place. The laser's down at the bottom here underneath that little lectern here, which you can't see. And then it's coming out through a fibre and going up into this lady's nose and down into her lungs. So it's all quite peaceful and easy to carry out. A lot of these cases are palliative. We very rarely get a patient that we can treat and cure other than skin PDT. Skins are great, but everything else, because we're not radiotherapy, surgery, chemotherapy, we get the ones that nobody else can do anything with. And you can see that we do get quite a lot of symptomatic relief. This is a trachea which was severely narrowed by lung cancer, and you can see the improvement. That lady could breathe. She wasn't spitting, coughing up blood all the time. Yes, she died from metastasis, but the 6 to 9 months that she lived were a much more peaceful time for her than she would have had if she had had this blockage in her trachea. I think this is the same patient, and you can see before that lung was completely useless and how we've managed to open the airway up there quite a bit. Again, the cholangiocarcinomas, which we've actually stopped at the moment, unfortunately, but we did get good results. It does depend on the collaboration and cooperation with other individuals in the hospital and what agendas there are within the hospital. But these were the results that we got. This is not a randomized controlled trial, so there may have been selection bias, not deliberately, but it's possible. One of the treatments for these patients is to stent them. So you can see the median survival if you put in a stent is 90 days. If you use chemotherapy, you get a much better survival, 186 days. And with our group of patients with PDT, we were getting 425 days, which is a very good result. The staging of the disease 2, 3, and 4 is a way of assessing the severity of the disease. So the bigger the number, the more severe the disease. And there does seem to be a reasonable division between the 3 groups. As I say, it's not a randomized controlled trial, but it doesn't look as if it was terribly biased in any particular direction. Now, I'm running out of time. This is brain. Here's our old laser, and we can see the fiber, and it's red, which means the laser light is on because it's a red beam, and it's going into the patient's head. This was one of our results not so long ago. We were using photodiagnosis for either PDT on its own or photodiagnosis assisted resection. And I think most of them are photodiagnosis assisted resection, although this is a wee bit of a mess, this result slide. So in this case, what happens if we're doing the photodiagnosis is the patient gets either photofrin or ALA. Then after the appropriate length of time, the surgeon then opens up the patient's head, has a wee look in, and he can recognize some tumor cells, some tumor tissue, and he removes it. Now, if you've got skin tumor, it doesn't matter if you lose a bit of healthy skin as well. That's fine. But in the brain, you don't want to be taking out bits of brain that you don't need to be taking out because, it's all quite useful. And the older you get, the more protective you become of what's left. It's a bit like the receding hairline. You want to hang on to what you've got. So what happens here is that after the surgeons cut out what he thinks is tumor, we then dim the lights and use a 4 or 5 nanometer laser diode or an LED, and then we can see little pockets of red fluorescence, and he then just cuts them out and pops them in a pot, and they go off to pathology. And you can see we've got this. We did a randomized controlled trial on this study. I don't know if this is actually the actual results from that study, but we did get a significant improvement in using photodiagnosis compared to just resection on its own. And that, I think that is from the study which was the randomized controlled trial. And you can see we are getting better survival than just treatment on its own. Now, I just want to finish with a few pictures because they're quite nice, quite pretty. That's one of the nice things about fluorescence. You do see some really nice pictures. I don't know, there's going to be quite a few people doing fluorescence work and presenting. I do envy you all these nice pictures. They're very pretty. This is what we call Bowen's disease, which is one of these conditions that you get on the skin. precancerous, although a certain percentage of them will eventually become cancerous. But in terms of metastasizing, it's a very, very low rate. Dim the lights, shine some violet, ultraviolet. Well, it's actually blue. Well, it's not. It's violet. It's 4 or 5 nanometers. It's always called blue light. I don't know why. Maybe because it looks blue. And you can see the red fluorescence in the lesion there. This was in the bladder. This is in white light, and it's difficult to know what you're looking at. And this is under fluorescence, under violet illumination, and that's the fluorescence. With bladder, you have to be very, very careful. You've got a lot of false positives because any inflammation will shine up as a positive. So you've got to do this work very carefully. We've got a study that we're about to publish where we've got some good differentiation between cancer and non-cancer, but there is an overlap, so it's quite a tricky area. And if you want to stick out your tongue, you can see, just to think you can see that that's white light, this is the violet light, and you can see there's a fair bit of red fluorescence on the tongue there. This is the palate, soft palate. Again, white light and under violet light. And you can see there's quite a lot of strong fluorescence there, which was removed. That was tumor. And I think there was also down there and possibly there as well. But you can see there's pockets of fluorescence everywhere because all cells produce PP9. So you will get a certain amount of fluorescence from normal, healthy cells. But where you're getting bright fluorescence, then that's an indicator that you may be seeing cancer. And of course, once you get physicists involved, then we don't just want to see pretty pictures, we want to measure things. So there's a soft palate, normal, and this is dysplastic. In other words, cancer changes in the palate there, in the oral cavity, and that's your red fluorescence that we were seeing earlier. You'll notice, of course, that normal cells are actually a little bit green. This is not calibrated, so that peak shouldn't be as big as this peak because we don't actually look green. You can see red fluorescence is red, but we don't really look green. But we are, all of us, producing autofluorescence round about 500 nanometers. So we are essentially little green men and women, although it's not terribly obvious. I think that's maybe somebody telling me I have to hurry up and stop. Okay, why do we bother doing PDT? Well, it can be used when surgery and radiotherapy isn't suitable. So, as I say, we often get patients who cannot be treated by any other means. You can repeat PDT. We've done it in some patients. We've treated systemic conditions 3 or 4 times. You can go back after 2 or 3 years and give another treatment. But with radiotherapy, you run out of options. It's quick. Well, it's fairly quick. You maybe have to sit around while the light's on, but that's all. Repeatable, that's the point I was making earlier. You can go back and do the treatment again. It offers hope beyond conventional therapy. Now, it's got to be realistic hope. I am not in favor at all of holding out unrealistic hope. In our unit, we are very, very strong in this. If we do not believe that the patient will get benefit from PDT, we will not do the treatment. We've got to be convinced within ourselves that there will most likely be benefit. There are clinics in different parts of the world. I don't want to point fingers at any particular part of the world. And they are doing what they call next generation PDT or sono PDT, where they're combining with ultrasound. Most of these clinics, when you examine their data, first of all, you'll find it's very hard to find the data. And secondly, whatever data you can find does not stand up to close scrutiny. Now, our results are published in peer-reviewed literature. So are the results from other respectable PDT centers. But these centers, which are doing next-generation PDT, they're not. I know because I was asked to referee one of the papers. I think it's probably the worst paper I have ever seen in my life. I'm making a political point here, which is that we don't do PDT a service by saying, yes, we can treat anything and everything. We can't. We have to be selective. And we have to say to centres that are doing PDT that we do not approve of, we have to say quite openly, I do not approve of what you're doing. I've said that. I've said it in the UK. There's a clinic there that we've had some very, very strong words. I've tried to get the government to close them down. Up until the moment, they haven't succeeded, but there are moves to get them closed down because it's not in the interests of PDT, and more importantly, it's not in the interest of the patient. Right, I'll get off my soapbox. Lecture over. Okay, PDT preserves appearance and function. So, you've been very well behaved. You haven't said a word. You haven't asked any difficult questions. And for that, I am truly grateful. Thank you.
First of all, thank you for your lecture. And in your experience with oral premalignant lesions, how do you do to keep the cream in the intraoral sites? Because here it's really hard to keep this.
To keep the cream?
The cream.
Just to store it? Or after you put it on the skin?
Intraoral. In intraoral.
Oral? Well,
because you might think 3 hours with this is really hard.
It's difficult, yeah. If you're working within a hospital, you can get somebody to make up a little sort of mask, and you can put the PDT cream in there. That's probably the most successful way of keeping it in place. You know, what do they call them? Oral technicians. They make up these little masks for putting in your mouth. I think that's the best way. There are some sites where it's difficult. Yeah, and some of the gynae sites are very tricky as well. The cervix, if you're trying to treat PDT in the cervix, it's tricky to keep it in place there as well. Yeah, but see if you can find an oral technician that will make up a little mask and put it in the mouth, and that should work.
Okay, thank you very much.
Okay.
It was a very interesting talk.
Right.
I have one question. It's not related to skin cancer, but normal, in general, ALA. So for ALA to get reduced to photofin, it probably has to have, the cell probably has to have a high metabolic rate and high mitochondrial activity. So do you think this thing will work in hypoxic tissues where the metabolism is much slower and the mitochondrial activity is much lower?
Yeah, I mean, obviously you do require oxygen, so hypoxic tissues would not be a good candidate for PDT. The question is, how much oxygen do you need? How quickly do you use it up? I mean, one of the things you can do, and it's been shown already, if you use low-level light, I'm not talking about low-level laser light therapy, but just a lower level of illumination, you get more phototoxicity than if you hit it with high wattage. And that's possibly because you're using up the available oxygen, although it's never been actually proven that that's the reason. If your cells are hypoxic, then I wouldn't, you'd be unlikely to get a good result with PDT.
Thank you.
Is there a minimum concentration of the photosensitizer that you need in order to conduct the therapy?
That's actually a good question. I don't know how you do this systemically, but we investigated this on the skin, and we used little chambers which have got a very accurate volume, and we did a whole series of experiments putting different amounts of ALA in this volume, and then we looked at the fluorescence over quite a course of time, and it didn't make any difference. So over an order of magnitude, it didn't make any difference. So yeah, I guess if you don't, there must be some level you can't go below, but we went down to what we thought were very low levels, and we still got exactly the same because we've measured it, we've published it. So within quite a large area. So in other words, a lot of the ALA that we were putting on just wasn't doing anything. It's not being used. It's just, you might as well throw it out the window or save your money, because we're Scottish, we think about the money.
My question is, first, is it expensive to receive such treatment? Second, is it open to everyone who wants this treatment, or you select the patients for experiment?
Okay. In terms of the cost, it's become more expensive because our hospital now requires us to use licensed products, and they are more expensive than the unlicensed products that we were using before. But there has been a cost comparison now. Colin Hopper is going to be speaking to you, I think, next week. And his unit in London published the economics of PDT compared to chemotherapy, compared to surgery, and PDT was the cheapest. So although all these things sound expensive, you find, in fact, the cost of PDT drug is nothing compared to the cost of a chemotherapy drug. In terms of skin, if you're allowed to use ALA that you can get and mix yourself, then it only costs a few dollars. We mixed it in, it was called unguentum merc, which is quite a good substance for penetrating into the skin. But of course, if you have to buy a licensed product, it gets more expensive. But it's not expensive. I mean, if you send somebody to a plastic surgeon to cut out and then skin graft, now we're talking expensive.
And is it open to everyone who wants to get this treatment?
Okay, good question. Within the UK, we have a National Health Service where treatment is given on the basis of need. So our charity funds certain treatments which are either not funded by the NHS or research projects. So we've got a number of research projects that we're funding. In terms of not funded by the NHS, Phoscan, which is one of the sensitizers that I showed you there, is not funded by our NHS in Scotland because they consider it's too expensive, so they won't pay for it. So our charity pays for that. So if you come to our hospital, either the NHS will pay for the treatment or our charity will pay for the treatment. But if you're from our area, you'll be treated for free. But if you're coming in from somewhere else, then you'll be charged. But that's fair, I think.
Thank you.
Okay, you're welcome.
I would like to know more about brain, because most of brain tumor has an infiltrative growth pattern. They are together. So, as you said, you are not really interested to damage some healthy cells.
Yeah.
So how you are, how you can overcome this problem?
Yeah. Well, one of the good things about brain is there's a very large differential between cancer uptake and normal uptake. It's about 100 to 1. The brain is actually the best organ for PDT in terms of preferential uptake. In skin, for example, it's only about 2 to 1. So in brain, you've got a lot more uptake by the cancer cells, so that gives you an advantage. You can do PDT, and we have done it, but because we work with a surgeon here, it's always happier at cutting things out a bit and then looking at what's left. So basically, most of our work at the moment is combining the fluorescence with the surgery. And that's giving us good results. We're getting extended lifetimes. Now, with a lot of these patients, they've got a very low life expectancy. And for example, we have a chap who came from Sweden. He was actually a physics professor that we treated. And that was about 3.5 years ago. I've just had an email from his wife to say that he has now relapsed and he's quite seriously ill. That's 3.5 years they've had. It's, it's worth something, isn't it? Okay, thanks. He also plays the saxophone. Just thought I'd mention that.
More questions? No. Thank you, Professor.
No, the gentleman at the back. Come on, I know it's a long way, but
I'm sorry.
Now, if he was a real gentleman, he would come down and get the microphone, of course.
Yeah, I forgot I had this question. So when you say sensitive to light, you don't mean someone needs to wear sunglasses. You mean?
Yeah, we do. We have a kit which we give the patient, and we will give them sunscreen and sunglasses, and depending on what they're doing, where they're going, we'll give them a sort of head covering, and we'll tell them to minimize the time outdoors. Now, the big problem is if they get their injection and then go home and come back again, that's a critical time because they're building up light sensitivity. We had a patient who went home and then had to come back into the hospital because they had sat in the car for half an hour with the light streaming in. Remember, it's visible light that will give you a PDT treatment. All that light pouring in through the window of the car. And of course, she had quite a lot of swellings, edema, which we, just Betnovate, some sort of cream. That's a steroid, isn't it? Yeah. See, I do know something. So a bit of steroid, and that's settled that down. But yeah, you've got to manage it quite carefully. We had somebody else who went home, and he was the Jaguar car. He was a Jaguar enthusiast, so he was busily polishing his car, not facing the sun, but of course it was reflecting off his car. So he got a bit of a light reaction, which we then had to treat. Yeah. So keep your car dirty, don't polish it.
The last question, okay?
You spoke a lot of the advantages of PDT. I just want to know what are some of the disadvantages, because it's not used as a conventional therapy for treatment of cancer.
Yeah. In terms of skin, I suppose the disadvantages, we do see recurrences, which we treat. Also, some people in some hospitals find this business of putting on the cream and then getting the patient back in and exposing them to light 4 to 6 hours later, they find that doesn't fit in with their normal schedules. Now, there's a way of dealing with that. We've developed this treatment we call ambulatory PDT, but that's for another day. But that's a kind of organizational aspect where you need to be set up so that you can get your patient back in, and if you're doing conventional PDT, put the lights on at that point. I suppose the main disadvantage in terms of systemic use is, we've talked about light sensitivity. The other is it doesn't always kill all the cells. So there's some cancers respond better than others. Guess that's true of any cancer treatment. Otherwise, nobody would die of cancer. But no, I think you have to take a balanced approach. I would not want to say PDT is the answer to everything, because I don't think it is. I think it helps with some patients. Right.
I just wanted to know more about the toxicity of PDT, like for the finger case that you...
The toxicity as opposed to the light toxicity. Not much. You may see blood pressure drop. So in some patients, you have to monitor them. Depending on what conditions they've got, that blood pressure drop may be important. I think that's probably the only general toxicity, general problem that I'm aware of, unless somebody else can fill me in with anything else. We've just done, I think we've either published or about to publish, a group of patients talking about this blood pressure drop in some of our urology patients. And it's not a problem, but you need to know about it.
What local ones, like fibrosis or these sort of things that you get with radiation?
Fibrosis or something like that? No. What you do get immediately after treatment is some edema, so you get tissue swelling. And we were a bit concerned, particularly when we started doing work in the brain, that could be a problem there. But it hasn't been. So as far as we know, it's not been a problem. There have been cases reported, for example, there was a lesion head and neck. I think, was it close to the carotid artery? And I think that caused a rupture of the carotid artery. And I think that probably led to patient death. So yeah, things can go wrong. Yeah.
Thank you, Professor.
Given the choice, you're better not to get cancer.
Thank you, Professor, again.